Alrighty guys, so today I'm going to go through the basics of the renal prac that we conducted. I started off talking about the structure of our nephron pretty much, and it spoke to us about the differences between our juxtamedullary and our cortical or our superficial nephrons. Now in this case there are some significant differences between these two. Now these two general classes of nephrons are both classified according to their location of their associated renal corpuscle, which we know contains our Bowman's capsule and our glomerulus. Now, our cortical nephrons have their renal corpuscle in their superficial renal cortex, which we can see on the diagram here. Now, while our renal corpuscle of our juxtamedullary nephron are located much closer to our renal medulla. Now, in most cases, the diagrams that we see in a lot of our textbooks are diagrams of our juxtamedullary nephrons, and this is because our loops of Henle in our juxtamedullary nephrons are much longer, whilst in our cortical nephrons these loops of Henle are much shorter and much difficult to see. However, our juxtamedullary nephrons only make up about 20% of the actual nephrons that are in our kidneys, whilst our cortical nephrons are the ones that are conducting and doing most of the work, most of the filtration work that are in our kidneys. So here are the cells of our proximal tubule. What we can see in this diagram are three distinct cells. We can see our interstitium, and we can also see on the top here our microvilli, and this is what we call our brush border. As we know with microvilli, their role is pretty much in increasing the surface area, which allows for, in this case, secretion and reabsorption of our solutes and our other macromolecules, which we want to be reabsorbing or secreting, but in most cases reabsorbing from our proximal tubule. And I'm going to go into a bit more detail on what solutes and what ions are reabsorbed and how this occurs right now. Now, before we go into what is absorbed on different points of our proximal tubule cell, it's important to understand our TF over P ratios. Now, following our filtration in our glomerulus, there are two processes which can obviously occur in our proximal tubule, and these are reabsorption and secretion. Now, the ratios that occur in comparison to our plasma, which is systemic plasma, and our tubular fluid, which is our fluid in our proximal tubule, at any one point can be considered in a ratio. And this ratio is the concentration of the substance in tubular fluid to its concentration in the plasma. And this is important, as our notes say, in giving us information about the relative rates of absorption and secretion of a substance in comparison to water, which we know is only ever reabsorbed. Water is not secreted. So if our TFP over ratio equals 1, then either there has been no reabsorption of the substance or reabsorption of the substance has been exactly proportional to the reabsorption of water. So say for example, if TFP over P for sodium equals 1, then the sodium concentration in our tubular fluid is identical to the sodium concentration in our plasma. Now this can be seen in the diagram that is taken from our text, and as we can see in this diagram, at the start of our proximal tubule, so just after our renal corpuscle, we can see that the TF over P ratio for sodium equals 1. This is because nothing has been reabsorbed at this point, and therefore the fluid in our proximal and our plasma must be exactly the same. Now, as we see, as the filtrate moves down our proximal tubule, through our proximal tubule, water is reabsorbed into our peritubular capillary, as we see in the diagram here, and so is sodium at exactly the same rate, and this is indicated in the diagram here, as we can see. Now, at the end of our proximal tubule, as we can see on our diagram, our TF over P ratio for sodium concentration equals 1, as our sodium has been reabsorbed directly in correlation with the amount of water which has been reabsorbed as well, and thus our TFP on ratio equals 1. So here we have a substance that is freely filtered into our proximal tubule but is not reabsorbed by our proximal tubule. And an example of this is inulin. Now, inulin is used medically to help measure kidney function by determining our glomerular filtration rate, which we also call the GFR in a shortened term. Now, our GFR is the measure of the volume of fluid being filtered from our renal glomerular capillaries into our Bowman's capsule over some form of unit time. Now, what this means is that the concentration of inulin in our tubular filtrate is much higher than the concentration of inulin in our plasma. And what this means is that we will get a TF/P ratio of greater than 1, usually in this case, as indicative in the diagram, of around 2.5. And our final case that we can look at is a substance that is fairly filtered from our plasma, that is not reabsorbed from our proximal tubule, but rather is secreted into the proximal tubule. And an example of this is a drug of some form, which we can see in this diagram. Now, in such a case, as we see, water and our drug are filtered from our plasma into our glomerulus, which travels into our proximal tubule. Now, as we can see in this diagram again, our H2O is reabsorbed by our proximal tubule back into our interstitial fluid, into our peritubular capillary. And we also see that there is the drug being secreted into our proximal tubule, which is leading to an increase in the concentration of the drug in our proximal tubule. And as can be seen at the end of our proximal tubule, this will lead to a greatly increased concentration of the drug in our tubular filtrate and a very much lessened concentration in our plasma due to the fact that there is drug being secreted into our tubular filtrate from our plasma, decreasing that value, which is in turn increasing the value in our tubular filtrate. And as such, the value for our TF/P ratio is usually greater than 2.5. So hopefully that makes some basic sense. Now what we're going to go through is the model that we had to create for proximal tubule cells, and the way in which our various ions, solutes, and various other components are reabsorbed and secreted across the various membranes of our proximal tubule cell. So what we can see in this diagram is the lumen of our proximal tubule. This is just above our brush border, which is indicative of the wavy lines that we can see now on microvilli. And on the other side we have our basolateral membrane, which interacts with our interstitium, and just below that we have our peritubular capillary. Now, as we know, fluid is filtered from our renal corpuscle into our proximal tubule, which is then reabsorbed into our interstitium through our proximal tubule cells. Now, in our proximal tubule, about 65% of the filtrate from our renal corpuscle is absorbed. This includes 65% of our water and 65% of our solutes, which include sodium, chloride, potassium, and hydrogen carbonate. And this is along with solutes such as glucose and amino acids, which in this diagram we have included purely as an X, just to indicate them in a broad collective term. Now, as we can see on our basolateral membrane, which is the membrane that borders our interstitium in our proximal tubule cells, we can see what are potassium sodium channels, which are ATPa's primary active transport channels, and it's this channel that really regulates the movement of solutes and molecules from our lumen into our interstitium. As we can also see, we have a potassium channel which recycles potassium and allows us to create an osmotic gradient, which ultimately provides a driving force for many other solutes to pass into our interstitium. Now, what we can also see is organic molecules, glucose, amino acids, indicative by this X that we see on our diagram, as being co-transported back into our interstitium, and what we term as secondary active transport.